Now the whole issue with the trigger points is, and my whole approach on it is very simple. Trigger points are either active, which they refer pain, which is familiar to the patient. They are latent, which they are painful to the touch, but they don't refer pain, or whatever pain they cause upon pressure on it, the patient is not familiar with it. And there's satellite trigger points. Trigger points are caused within the referral pattern of active trigger points. And there are also attachment trigger points, which stem in the muscular tendinous attachment of the muscle right to where the muscle becomes a tendon near the bone where they attach. Now we're on the semispinalis capitis, and we got an active trigger point which refers to the jaw. And central trigger points will cause satellites. My approach on it is just treat them all. There's no way to know which one is really active or not. Is this referring anywhere?
No.
Okay. So now I'm going to go to the sternocleidomastoid. Now this muscle can be quite painful and harbors many trigger points, mainly usually involved. Okay, its referral pattern usually stems on the cheek, the forehead, temporal area, often harbors central trigger points, involved in headaches, sore throat, what they call ataxia, means someone will veer to the side while walking without even noticing it, dysmetria, someone will perceive weight when they hold weight as lighter on the side of involvement. Now, this muscle is involved in a lot of issues. Vertigo, and what I will do is a fascial stretch on the SCM. I will separate it from the carotid artery and the baroreceptors. Okay. Now, I will stretch this muscle from mid-belly to the extremities to avoid excessive tension on the attachments. Now we'll do an active release on the attachment of the sternal head. This muscle is comprised of two heads, the sternal and clavicular head. The sternal head attaches by the sternoclavicular ligament. I will simply apply light pressure as it can be painful. And I will rotate the head to the same side. Now, if I stick the thumb a little deeper, as such, I'm going to ask Elena to take a deep breath and hold it. With light friction, I will treat the sternohyoid and the sternothyroid. Fully exhale. Now we'll treat the scalenes, rotating the head to the contralateral side, and now let's first treat the anterior scalene. Now, anterior scalene is often involved in scalene anterior syndrome with radiation, referral pain down the arm, the shoulder, posteriorly to the side, all the way to the pinky finger. Also, the referral pattern of that scalene anterior will be on the superior angle, on the top angle of the scapula, between the top angle and the spine. Now, this muscle attaches to the first rib, so I will slightly put my thumb deep to the clavicle, to the first attachment on the first rib. Okay. Can be painful. First, you set it with light pressure. Check with the patient. If it's appropriate, induce friction.